लाइट वेट कर रहे हैं,
गैस बंद कर दे। गुड मॉर्निंग डॉक्टर जेठानी।
Good morning, sir. Good morning, ma'am. A lot of known people are there. Yogita madam, right? Everybody is known.
So we can start now.
Should I share the screen, sir?
अच्छा नहीं मैं करूँ।
Share करूँ sir screen?
Okay. Good morning, all. Welcome back to Saturday Club morning meeting. And today we have a very eminent speaker. No, just hold on. I will introduce you. Let me first. This YouTube is echoing, so I will first stop it.
Pediatric eye infections.
मामा के बहुत काज करके अभी हो रहा है सीरियस
Sorry, I was busy with that live streaming. It was echoing. So, good morning, friends. Welcome back to Saturday Club meeting. And we have very eminent speaker today, Dr. Jitendra Jethani. He is a pediatric ophthalmologist practicing in Baroda for almost 2 decades now. And he has a very illustrious career spanning over last 2 decades. I'll briefly just read out his CV because when I went through his CV, I was very impressed with the number of awards that he has won. I mean, there's a whole list of awards. I can't read out all, but I'll just briefly introduce him as a consultant pediatric ophthalmologist in Vadodara. He has done his fellowship in pediatric ophthalmology, FNB, fellow of National Board. It was a 2-year fellowship at Arvind Eye Hospital, Madurai. He has also had stint at University of Wisconsin and All India Collegium of Ophthalmology. And as I said, he has several awards to his credit for his work in pediatric ophthalmology and especially in strabismus. He has more than 50 publications and more than 100 presentations. So we have a very knowledgeable pediatric ophthalmologist with us today to talk to us about common problems, eye problems in children. So over to you, Dr. Jethani. You have about 40-45 minutes and then we'll have 10 minutes of discussion. So over to you. Thank you.
So thank you so much, sir. And I mean, I have a good career, good number of patients only because of the support from the pediatrics in Baroda. I mean, I would just say that I was lucky. It was a lucky break that I started in Vadodara. That was around in 2008, and I have never looked back because most of the people welcomed me so nicely, and there always used to be good number of referrals. So I never had to go back to Ahmedabad. So I did my graduation from Ahmedabad, but it was, I mean, I feel fortunate, and I keep telling all my students that, you know, Baroda is so different from Ahmedabad. I never had to think that, you know, there will be a dearth of patients or there will be dearth of love that I got in the city. So thank you so much. Thank you so much, as always. So I would be speaking on common eye problems in children. Now, this is not a very small subject, and I have got a lot of good time here. So we will try to cover most of the problems. This is a pretty basic model of eye, just to well versed with the key terms. These are just the basic. All of us here know these things. Now, good vision, normally what, as an ophthalmologist, we also sometimes go ahead and think that good vision only means visual acuity. But part of the good vision also means color vision. Part of the good vision also means visual integration, reading speed, eye focus, and motility. And more so this is known to, more so it is important when we have kids who have delay in their development. Then we realize that, reading speed, eye focusing, cognition, this becomes important. Whereas otherwise, we just think about visual acuity and Snellen's chart. That is what we see. So this is the most common. This is the most common common problem that we see in kids. The most common out of this is nearsightedness, that is also known as myopia. And then there is farsightedness, astigmatism, and anisometropia, which means that there is unequal refractive error in two eyes. So what is myopia? This is again pretty simple, that, the eyeball is either long or the corneal curvature is more steep. And so the focus is just before the retina, and what it should be like this. So we put a diverging lens, it gets treated. Now, why myopia is being discussed separately is because we'll see. We just tried. So this was in 2010 that there was a wonderful article which projected that there would be an increase in myopia population by almost 52%. Now this is prevalence. So because myopia is a chronic disease, it is not going to go away. This is not incident. This is prevalence of myopia would be 52% in general population across the globe. This is all extrapolated data, but in 2010 it was 28%, and gradually it will progress to 52%, with 10% being high myopes. So this is very, very important, and that is why I have put few more slides on myopia. And this is how it would be distributed across the globe. Now, myopia, we have gradually realized that both genetics, both nature and nurture are related with myopia. This is very important. They have found out now, they have come to a conclusion that if one of the parent is myope, the chances of kid having myopia is 2 times. And if both the parents are myope, the chances of kid having myopia is almost 5 times the normal population. This is very, very important. And another very important slide is that now it has been, initially there used to be some argument whether outdoor activities do relate to myopia prevention, which means that there is always a gradual progress of myopia as the age grows, especially in children. This does not happen in adults because their height increase is restricted, their eyeball size does not increase after 18 years of age. But in children, it gradually progresses, and now it has been very much established that if you have less outdoor exposure, more near work, this is going to increase the glass power. That is what in common terms we would say, but it would increase the myoaxial length of the eyeball. So this is just a small picture timeline to show how myopia has progressed since 1980, maybe because of urbanization, maybe because of digital devices, maybe because of more near work and less outdoor activities. So this is another interesting article which was published in Singapore and Denmark, because they are small countries and they could actually do height, and they could follow up the patient for at least 3 to 4 years, and they could find out what was the relationship between height and eye size. So what they found was that before 2 years, before the height spurts begins, the eyeball size starts increasing, which means that around 7 to 8 years of age, the eyeball size gradually starts increasing, and height starts increasing at 10 years. This was from their own article, and they found that this was more seen in girls, as not as commonly in boys. And they concluded that because girls at this point of time reduce their outdoor load and reduce their contact sports and all those activities, and so myopia is seen more commonly in girls in that part of the world. So outdoor activity, parental myopia, near work, amount of light, this is now, these are some of the risk factors for myopia in school-going children. There's a wonderful article published in 2020. What they have done a meta-analysis. They have tried to find out all the articles published similar to Cochrane database, and they tried to find out what are the risk factors for myopia. But the only difference between this and Cochrane is that they have also gone for anecdotal studies also. So these are the risk factors for myopia in school-going children. Another interesting thought process was whether vitamin D was associated with myopia, and they found that vitamin D was substantially low in children who were having progression of myopia, and then they tried to link it with myopia, but they found that it was more about spending outdoor time and less about actual vitamin D concentration in the body. These are some of the problems, the complications of myopia and why it is important. This is a new drug which has come up for myopia, and this is just to show the studies which we have also conducted in Baroda. In Baroda, we were the first in the country to start. I mean, this particular study was one of the first in the country to start using atropine for low concentration atropine for myopia. And at that point of time, we had to take ethical clearances. We had to reconstitute atropine because it was available only in 1% and not in 0.01%. And now, fortunately, with those efforts, we could find out. Now there are, there is Sun Pharma and there are big companies now which are manufacturing it. So now it is very readily available. We also tried to do some study to find out whether indoor activities do make a difference or not. And we found that, in quarantine, the jump of myopia was huge. So that also clearly indicates that indoor activities do make a difference. And these are some of the, we made this video more for schools and general population, just to tell them the harmful effects of screen time and the things which screen time can do. More screen time can increase the progression of myopia, can increase the glass power, or can generate glass power in children who do not have myopia. So there are a lot of patients, everybody must be seeing in their OPD, who have now got glasses, mainly because of more and more online work. But this was just an awareness video which we made during quarantine, and that was that. And so other refractive errors are hyperopia and astigmatism. Now, hyperopia means that the eyeball size is small, and so the rays do not focus on the on the retina, and that is commonly known as the plus power. So this normally the length of the eyeball increases, and so in childhood hyperopia of around +2 to +3 may get corrected on its own with the normal physiological growth of the eyeball. So normally the child who is born at birth, he will have a glass power of around +2.5 to +3, and gradually as the lens and corneal curvature, lens will become thin and cornea will also become gradually flat, and this will increase in size, and that would reduce the physiological hyperopia. So till 5 to 8 years of age, we call it hyperopia, but it is a physiological hyperopia. And if patients do not complain, we normally do not prescribe glasses in these patients. Now, if at all a child is having anisometropia or having a refractive error, which is, the child is not able to compensate, and the vision is not clear, so the image is not forming on the retina clearly, the eye can go into amblyopia, which is unilateral or bilateral loss of vision, for which there is no organic cause. The only cause is that that particular eye was not used in common terms, and in our terms was not stimulated properly, and so ended up being lazy. So the treatment is very simple. We have to start making sure that you have to patch the better eye, so that the eye which is amblyopic, the eye which is not able to see, should be put to use, and they should start using the eye to get good vision. Now, other common complaints, other common problems are strabismus. Now, normally with strabismus, we have to act very early, because strabismus can cause amblyopia. Apart from refractive errors causing amblyopia, if we talk about this child, he has small telecanthus. So this is a little bit of telecanthus is there, but he has a clear-cut left eye esotropia. So this particular eye, he will stop using, and this eye will go for amblyopia. This eye will become lazy. So we have to patch this eye, and once the vision recovers in this eye, we can operate and make it straight, so that he doesn't need to patch further. So his amblyopia is treated. So amblyopia has to be treated first before strabismus, and then strabismus has to be treated so that amblyopia does not come back. So we recently, I think we had to operate. So this is esotropia. You operate this before 1 year of age. This is exotropia. The eye is out, and this is just to show the results. So before we move on to this, I just want to put a small point that in exotropia, you normally do not operate at a very young age. But if it is a constant exotropia, you may have to operate at a very young age also. We recently operated a 10-month-old kid at Kashiba Children's Hospital, because the kid had constant exotropia. So normally, exotropia patients, if at birth they have exotropia, that is known as congenital exotropia, and we have to do neuroimaging in these patients. Whereas congenital esotropia or infantile esotropia, nowadays there is nothing like congenital exo or congenital exo. We call it as infantile exo and infantile exo, taking into consideration that normally strabismus would start only after 5 months of age. Before that, if there is a strabismus, we would like to wait and watch, and the child may improve on its own by the age of 6 to 7 months. So infantile ESO or infantile exotropia, the only difference is that in infantile exotropia or congenital exotropia, we have to go for neuroimaging, because the congenital exotropia is a soft sign for neurological disease. So that is just a point I wanted to make. And there is another thought process about why should we screen for vision, because early intervention is the most important intervention in these kids. See, in children, what is more important is that they get maximum amount of information and knowledge from their eyes. Almost 80% of thought process and 80% of input that they receive is through the eyes. And so if their visual acuity is not good, there's a good chance that kid may actually have some other issues which we may think that he is having because of the systemic conditions, and it may be actually because he may not be good in studies because he is not able to see things properly. So it is very, very important to do early diagnosis of refractive error, and most important is to correct those refractive errors and to tell patients that, so I commonly tell parents that, it is more about a parent's mindset of not wearing glasses and not about the kid, because the kid is bound to see things clearly, and once the kid sees things clearly, he is bound to use the glasses. So that is how it is very, very important that the child should be told to wear glasses, and parents should be instructed that child would be wearing glasses. It is not at all a problem. So another common problem in children is watery eyes. Now, the most common causes are congenital nasolacrimal duct obstruction. So it can be differentiated from other form of conjunctivitis by the fact that the history would be there since birth. There will be matting of lashes, and once we press the lacrimal in the lacrimal fossa, if we press here, there will be a clear gush of discharge, or so there will be the Ropla's test will be positive, and there will be some discharge which will come. So that settles the diagnosis of congenital nasolacrimal duct obstruction. And other common causes are allergic conjunctivitis, bacterial and viral conjunctivitis. Now we know that whenever we have allergic conjunctivitis, we go for steroids, and whenever we have bacterial conjunctivitis, steroids is a complete contraindication. So it's quite simple to differentiate allergic conjunctivitis. There are very big pointers for that. Normally, allergic conjunctivitis patients will complain of itching. They will have multiple episodes of this particular conjunctivitis. A very good sign was found by an Indian ophthalmologist for the first time was that there would be pigmentation on the conjunctiva, which suggests that this particular patient does have allergic conjunctivitis. And if you can avert the lid, you can see the papillary hypertrophy or papillas under the lid. So this is very easy to differentiate that whether there is any infection or not. And then bacterial conjunctivitis, viral conjunctivitis, it's very easy because bacterial conjunctivitis, there will always be a discharge. And viral conjunctivitis normally will have more of watery eyes, and there will be an incidence that family has. Viral conjunctivitis is indeed contagious because of pox virus. So it is normally contagious, and we always normally give antibiotics even when there is viral conjunctivitis, because we want to prevent secondary infection. So we do not normally give steroids here, and lot of topical steroids there. Pediatric cataract, I know it is not a common eye problem, but pediatric cataract is a very important eye problem, and it is potentially a blinding condition, especially in children, not in adults. In adults, it is more like graying of hair. It is more like physiological thing, and it is going to happen to most of us who would live enough. So cataract is not a problem in adults. It is a problem which can be solved with certainty, and the results can be almost 95 to 98%. The visual rehabilitation is very good, very quick in adult cataract. In pediatric cataract, it is a completely different ball game, because when a kid has cataract, his growth of eye his vision development itself is impaired, because he can end up having amblyopia. He can end up having very poor visual acuity. More important is that, pediatric cataract, the diagnosis itself is a problem, because parents do not think that, their kid has a problem. And with some children having rubella, like this is the rubella cataract, I know they have other problems itself. I mean, they have problems of congenital heart disease. So they are too busy to, circumvent those systemic problems, failure to thrive. There's so many things. I mean, we operated a kid with hair lip, and there's so many things which are going on together, because if there is a congenital cataract, the kid is bound to have multiple, there can be multiple problems, because if it is there since birth, there is bound to have other malformations of other body systems also. So pediatric cataract is very important, if not very common. And I think once we have a pediatric cataract, we have to operate the child as soon as possible, because visual rehabilitation in kids doesn't mean getting visual acuity. I mean, once we operate, the kid may not have good vision, but gradually as the eye is stimulated, the vision comes back. So it is very, very important that we should get these patients, find out these patients as early as possible and rehabilitate them, because post cataract, they also need to wear glasses, and parents have to be told that after pediatric cataract, they need to wear glasses. It is not like adult cataract where the glasses are as and when basis. In kids, they have to wear glasses, and the glass power would change every 6 months to 1 year. There's a possibility that the kid pediatric cataract, if operated very early, may develop glaucoma and may need visual rehabilitation for that also. So not very common, but very, very, very important. Now this is just to talk about the etiology of pediatric cataract, and as I was saying that in majority of the cases there is absolutely no etiology. I mean, we cannot even establish the etiology. Can be all these things apart from being hereditary pediatric cataracts. So this is again, I mean, these are again common slides for kids. Most of the kids do all this because of quarantine. They have to read for long hours. They've started using computers, and all these things do lead to these all activities. They are now known to have. They are all boosters for dry eye. This is all. I mean, this is all taken from reliable data, where they have suggested that if you use more computers, more reading hours, insufficient light, it stimulates. I gradually go for dryness, because it is not that our lacrimal gland is not making sufficient tears. It is the blink which goes away. With all this, gradually the blink response goes away, and we have to blink at least 19 to 20 times in a minute, and we stop doing that. And this is all food is good in omega-3 fatty acid. So that is what we talk about when we talk about dry eye. We want more and more omega-3 fatty acid, because it stimulates the lacrimal gland to make more aqueous. I mean, more aqueous part of the tears, not the aqueous humor, but the tear has 3 layers, and there is lipid, and then there is aqueous layer, and the posterior part is mucin layer, which is by vitamin A. So that is why there is vitamin A which is needed, omega-3 which is needed, and lipid is needed from meibomian glands. So this was just regarding these are just small pointers regarding dryness, because more and more people, more and more children. So normally we were not seeing many children having dry eyes, but post quarantine and post after the quarantine has ended, there are more and more children who are coming with rubbing of eyes, blinking their eyes more frequently by seeing TV and computers. And so dry eye cannot be treated purely with lubricating eye drops. So we have to do some modifications in our lifestyle to have a better life with dry eye, because if it occurs at a very young age, it becomes very difficult to treat, because this is just to talk about how to use computers. And then we move on to a lot of small myths about eye problems in children. And a lot of parents do believe that glasses may increase by using computers, and so partially it is correct also, but it is not correct in the sense that when you use things for near, whether it is computers or whether you are you are reading or writing, everything. Just a minute, my battery is going to go. So when you are using, whenever you are using computers or you are using television or anything, you strain for near, and that usually causes the increase in glass power in children. In adults, it does not make a difference except that your blink rate is reduced. And then wearing wrong kind of glasses will damage your eyes. If you wear wrong kind of glasses, it is again partially correct, because if you are less than 8 years of age and your eyeglasses are wrong, there is a possibility that you may end up with having lazy eye or amblyopia. Now, how do we check? I have a slide on that also, but I would just make a point here only. How do we check glass power in children? A lot of times, we go to opticians and they check our glass power with the help of computers or with the help of auto refractor, which is very good machine to get a broad guideline as to what is exactly our glass power, mainly for adults, because adults do not have a strong accommodation. But in kids, they have very strong accommodation, and we have to use cycloplegic eye drops to dilate their eyes and check their glass power, because only then we can be sure that they have a particular kind of glass power or not. So that has to be kept in mind. This also, we talked about how a lot of by the time a kid is 6 months, and if he still has crossed eyes, there is a good possibility that this cross eye is going to remain for the rest of the life if not treated. So it has to be treated early to prevent any amblyopia, to prevent any future problem. It has to be treated with patching. Once the amblyopia is treated, we can go for surgery, and we can, once we go for surgery, he may not develop amblyopia after surgery if it has been treated. Now these are not part of the. Okay, now this is another good, we can have good discussion on this, that myopia, commonly what we get is minus power and hyperopia plus power. But a lot of times the questions are asked on what exactly is astigmatism. Now, astigmatism is basically the corneal curvature. The cornea is a spherical structure. So corneal curvature, there is a vertical curvature and there is a horizontal curvature across 0 to 360 degrees. Now, if one of the curvatures is more curved compared to another curvature, which means that if at 90 degrees the power is around 44, and if at horizontal it is 42, then that two diopter, which is the difference between the horizontal axis and the vertical axis, that particular power is cylindrical power, and cylindrical power is always at an axis. So that solves the astigmatism, and this is all. This is for common general population. These are sitting close to a television can increase the myopia. This is very important. In fact, sitting close to television is an important sign to get the eyes checked. It may not damage the child's eye, but it is very, very important. It is a very important sign that kid needs glasses because he's not able to see from distance. So if the child is complaining of face turn, if the child is going close to the television, there is a good chance that this particular child may have glasses because he's not able to see things clearly. He's not able to see properly, and this particular child would definitely need an ophthalmologist to look into what is going on. This is also very common that we keep telling parents that they should not use kajal or anything in the eye. It doesn't help in any way. I have kept this slide only because I was going to talk on common eye problems in children, but I took this slide mainly because to send a message that kajal has got absolutely no role, nothing, and we normally do educate the parents, and we should all keep telling them that this is important. It may end up into the people may end up into developing problems because of kajal, they may end up into having bacterial conjunctivitis because of that. But this is what I was talking about computerized eye test. This is a simple autorefractor. The simple principle of autorefractor is that there's a Schneider's disc inside this, and they send some light which goes inside the eye, comes back, and the distance is measured, and also it is measured as what is the refractive error in the central 3 to 4 millimeter of the eye. So what it does is it does not take into consideration your own accommodation. What is accommodation? Accommodation is your ability to see for distance and near at the same time. Like you can see at distance, you can see at near. It doesn't take time for you to accommodate. Once you are above 40 years of age, this particular ability of accommodation gradually starts going away. And when you are around 42, 43, you need glasses for near, and that is known as presbyopic glasses. And in common language, we call it Betala Chashma. So this particular ability of accommodation in children is huge. I mean, they can accommodate up to 10 diopters. And so when the kids are told to keep their chin here, they start accommodating, and we may end up into erroneously thinking that they have a minus glass power, or if they have a +4 or +5 glass power, the computer will show that they do not have a glass power. And so we need to put sacropelagic eye drops like atropine, homatropine, or sacropentalate eye drops just to be sure that their accommodation is at rest. They're not able to accommodate, and we then test the glass power to find out the actual data, to find out the actual glass power that they have. So that is very, very important, especially in children, that you don't have to do computerized eye test, but you have to do a sacropelagic eye test. So that was regarding common eye problems. We can discuss the questions.
Yeah. Thank you, Dr. Jetani. I know that was a very comprehensive overview of common problems in children, but I'm sure there are a lot of pediatricians here and they have many questions. So we keep it open for everybody. Anybody who wants to know more about pediatric ophthalmic problem can ask. I can start with my own question. You mentioned about LED lamps. Is there anything special about LED lamps which would cause eye issue?
No, sir. Actually, the LED lamps, there was a study in China which was not really a RCT, but they did a study to find out whether LED lamps cause an increase in glass power or not. Mm-hmm. So they found that LED lamps do. So this was compared with outdoor activity.
Okay.
And this was also compared with normal neon lamps. So they found that the children who were reading or writing under LED lamps, the glass power progression was more. But this is not based on my data, but just to be just among friends, I can tell that a lot of Chinese studies published a lot of things, but it was there in that meta-analysis. And so we keep telling that LED lamps should not be used. I don't really know why there is, how it does work. And there was no data on how LED lamps stimulates the growth of eye.
Because LED lamps are promoted to save energy, I think that's
yes.
Another thing about you mentioned low concentration atropine for myopia. I mean, is that a routinely used medication? So,
to be honest, it all started when in 2012 we started using low concentration atropine. We published our data. There were another group which published in 2021. Now it is a purely established modality that if there is a progression of myopia, if the glass power is progressing, eye doctors or at least pediatric ophthalmologists would suggest that you can use atropine. There are special glasses, MyoSmart glasses, which also can be used. Blue blocking glasses should be avoided for patients who can develop myopia.
So what is the duration of this therapy?
2 years, sir.
Okay. I think Dr. Shulin had asked about management of allergic conjunctivitis.
So allergic conjunctivitis is a difficult thing to treat. We can draw parallels with allergic asthma. There is absolutely no difference. It is type 4 hypersensitivity. Allergic conjunctivitis or vernal keratoconjunctivitis is similar to that. There will be episodes every now and then. We treat them with low concentration steroids like loteprednolol. The problem is that loteprednolol or any other steroid predisposes the child towards having glaucoma or cataract. So we have to keep an eye on that. The minimum duration which can lead to glaucoma is 1.5 months to 2 months if we use it constantly. These patients are steroid responders. So we start with loteprednolone, but we check their pressure on every visit and taper it off, just like we do with systemic steroids. And we add some anti-allergic, like antihistaminic. We have, at this point of time, we have got newer antihistaminics after olopatadine. Now they have got bipostatin. These are new antihistaminics. So they say that it blocks HT1, it blocks all the receptors, but it is not as effective as steroids. Then we use cyclosporin. There is a lot of interest in cyclosporin and tacrolimus eye ointment, which is also used for allergic conjunctivitis very frequently. So this is the primary way of treating allergic conjunctivitis. We start with steroids and anti-allergic or olopatadine, and then we give cyclosporin for at least 2.5 months. So cyclosporin is a low potency anti-inflammatory drug which doesn't have side effects like steroids. And sometimes we also use NSAID eye drops like bromfenac, ketorolac.
How is meibomian gland disease related to dry eye?
That's very interesting. So what happens is that your tear film has 3 layers. The outer layer facing towards the atmosphere is lipid. The way nature has wonderfully designed it is that lipid is when in contact with air. So lipid protects evaporation of that particular water there. So if lipid secretion is reduced, or if meibomian gland secretion reduces, then immediately you will have evaporative dry eye. When we reduce our blinking, with each blink, eye basically just like you have wipers on the windscreen. Similarly, the eyes, once we close the eye and open the eye, the lipid layer is there on the aqueous layer, and if you reduce your blink rate, what will happen is that lipid layer will not be able to coat the aqueous layer, and that will cause dry eye.
I will read out few questions from the chat box. For first month of age, how can we judge the vision where there is less eye contact with other?
So at 1 month of age, we actually do not expect eye contact. At 1 month of age, we just have to see whether the eye is anatomically normal or not. By the time it is 2.5 months, the eye contact and everything will be there. If it is not there till 2.5 months of age, we have to find out whether there is any problem any anatomical problem is there or not. And if we feel that there is a developmental delay or issues like that, then there is a term known as delayed visual maturation. So that is also possible, not very common. So we should not think about rare things. We should think of a problem if the child doesn't have eye contact by 2.5 months. We have to find out whether there's any anatomical problem or not. There is no good way except with the torch. You can switch off the light, reduce any noise, and just move the torch, and you can find out whether the child is looking at the torch or not. So that is a good, robust way of finding out in that particular age. Even visual evoked potentials, VP, can only find out good vision after 6 months or 7 months of age. So before that, it has to be clinical.
One Dr. Kinsuk has asked about NLD block as to till what time we wait till it to get opened up.
So normally we wait till 8 to 9 months of age for it to get opened up. There are advocates of doing a quick probing at an early age, but the structures are so thin that chances of false perforation or we may perforate or we may have a false opening at somewhere else are very high. And there's good data which suggests that at least till 8 months or 9 months of age, it opens on its own by almost 90 to 92%. So that's a good number. And as such, it does not affect visual acuity. The only thing which we have to remember is that it has been found that children who have congenital nasolacrimal duct obstruction do have a higher numbers of refractive errors. So we have to check them for refractive at 1 year of age.
So what is the exact way in which to do the NLD massage? Because I see a lot of children who have been advised differently about how to exactly do the massage.
Normally, what I will just show you on myself. You have to take the upper and lower canthus and press with the small finger. Hold the child's head and press here, and then you can go down like this. So it is mainly about the hydrostatic massage that you are pressing here.
Right.
And then you can go down.
And then there is a question from Dr. Kairvi. Does use of Budecort inhaler, that is inhaled corticosteroid, given for asthma prophylaxis, increase the chance of cataract later?
I have not really seen a patient who has developed because of this. He has developed a cataract, and I have seen a lot of patients who had been given steroids for nephrotic syndrome developing cataract. But with this particular therapy, I have not really seen any pediatric cataract.
You are right, because even asthma training module doesn't talk about cataract as a side effect of ICS, that is inhaled corticosteroids. Then Dr. Yogita wants to know about what age routine eye refraction should be measured. Like, say, how frequently we should look at these children for
every 6 months. We should check the kid. First checkup should be done at 2 years of age. If the child is preterm, we should do the first checkup at 6.5 months of age to 1 year of age, because preterm babies are more prone towards having glass power. And term infants, if there is no family history, we can wait till 2 years of age, because till 2 years of age, we are even otherwise not going to prescribe a small refractive error. Even if they have a very small refractive error, we will not prescribe. So glass prescription in children, if the glass power is more than 4 or 5 in plus power, only then we will prescribe. In minus power, we will prescribe anything more than 2 diopters under 2 years of age. Above 2 years of age, any power they have, we will be prescribing, but not less than 0.5 diopters.
Right. Then there is a question from Dr. Sudhi. In case of isolated bilateral microphthalmia, any other anomalies of eye known?
No. So if you have microphthalmia, the whole eyeball is small. All the small organ systems inside the eye would have problems. The lens will be small. There can be coloboma, optic nerve coloboma, retrocoroidal coloboma. Optic nerve itself may be having the size may be smaller. So, I mean, there are a lot of problems. Problem with microphthalmia is that at this point of time, we do not have any concrete treatment protocol for microphthalmia who have other congenital problems. So there can be small eyes, microcornea can be there with good vision also, but those are lucky children who escape with good vision.
Dr. Kinsuga has raised a very commonly asked question, and that is relationship of headache with refractory error.
So commonly, we call it, there is a whole lot of symptoms which are known as asthenopic symptoms. By talking with the kid, see, I get a lot of referrals where the parents have gone to the pediatrician, and pediatrician has told them you get the eyes checked, and they get a refractive error of 0.5 diopter. Now this becomes a catch-22 situation, because now this boy has got a half diopter, and if I prescribe him half diopter, he is going to wear the glasses for the rest of his life. Nobody is going to tell him that don't wear glasses. So we have to talk with the patient and ask him when headache occurs. Does it occur early morning? If it occurs early morning, then 99% it is not because of the eye, because he had a good sleep. Why he should have headache early morning? Then we have to ask them whether it occurs after watching television or after studies. If it does not happen after watching television but happens after studies, he is probably faking it, because if he has headache after his television, then he will, it has to be with the eye use. Once he uses his eye and develops headache, it means that, but for a common practitioner, I would say that if the kid has headache and if it correlates with his eye work, then we should get his eyes checked.
I think all questions in the chat box have been addressed. This is a very heterogeneous audience here. Tell us something about ROP. People are not aware about ROP, general public.
Yes. So ROP or retinopathy of prematurity occurs mainly in kids who are preterm, and especially when the kids are born before 36 weeks of pregnancy. Mainly ROP occurs in children who do not, who need some oxygen post birth, and initially it all started in 1949 when they found that they are developing more and more problems. All the preterm babies are having retinal detachment and they are blind. So ROP occurs, it is more or less a iatrogenic disease. That is what was questioned, whether it is really an iatrogenic disease and whether it will occur otherwise or not. So it can occur even otherwise also. So it is not just that oxygen, giving oxygen is responsible for that, but the fact that baby has a sickness score, baby had a respiratory disease, baby had a low birth weight, anemia. Most important nowadays is anemia for ROP. And ROP is almost 95 to 100% treatable in children who are screened for ROP. So we should, it is also a medical legal issue with ROP, because if we do not refer the baby for eye checkup and baby develops ROP. Recently, we had a child who was sent to us very, very late, and the child almost had a retinal detachment, and the kids are, the parents have nowhere else to go, because they were not told about it, not from Baroda, they were referred from outside. So but my point, and very relevantly raised by sir, is that retinopathy of prematurity is something which can be treated. It is one of those rare conditions in pediatric population which can be treated 100%, because most of the pediatric problems, we always tell the patient that we cannot treat it 100%. So ROP is something we know that if we do a proper laser, or we do give intravitreal injection of anti-VEGF at a perfect stage, the child will not have problems in his vision. The child will not have problems in vision, and so that is very important to realize or to recognize it early.
Right. I think this question was answered, but you can repeat it. Dr. Yogita Chan especially is interested about adolescent missing out on refractory errors. So what should be the protocol, like how frequently they should be?
I think we should check them every 6 months to 1 year, because, and if we are suspecting if there is a history of parental myopia or glasses, then we should do it every 6 months.
And somebody is also asking, Dr. Anil Shah is asking about operation, surgery. At what age should be surgery should be done for squint?
Squint has to be operated as early as possible if it is constant exotropia. If there is amblyopia, we have to treat amblyopia first and then operate squint. It's a full separate lecture. What are the advantages of operating strabismus? Because normally we as general people feel that squint means it is more of a cosmetic thing. Squint is not about cosmesis. See, I will just give one point here. If one of your eye is out, you will be seeing with only one eye. You will be seeing only this much field. The rest of the field is not visible because you're not using that eye. So you do not have binocular visual field. I'm not talking about 3D vision. I am just talking about uniocular field. You're only looking on the left side. Anything comes from the right side, you will not be able to handle it. So squint is not just cosmetic. It is purely functional. And that is where a lot of our claims also get rejected by insurance, saying that squint is a cosmetic disease. It is not at all. There is nothing to do with cosmesis and strabismus. It is purely a functional disease. Only people who are operated for strabismus can vouch for that. And unfortunately or fortunately, there are not many medical practitioners having strabismus. So they cannot vouch for it, that what are the advantages of treatment of strabismus.
Very true. Something about glaucoma. What is the prevalence of glaucoma in children?
Very rare, sir. It is not actually common. Pediatric glaucoma is very rare condition. To be honest, I would see, being in a purely pediatric ophthalmic practice, I see in one patient in a month, new patient, and that is also very high. That is very high because I see only pediatric patients. But general ophthalmologists would see one patient in 6 months. So fortunately, pediatric glaucoma are very difficult to treat. Most of the pediatric glaucomas, the prognosis is not very good. Even when we operate as early as 4 days or 10 days, the visual acuity regain is there, but it is not more than 80% in most of the cases.
Do you
And
think
we
it
need
is
to
a very
know-
commonly missed condition in children? I mean, they report late. I mean, the pediatricians miss out on detecting this glaucoma.
Normally, pediatric glaucoma is such a strong condition that actually pediatricians would miss more of refractive errors, strabismus, and pediatric cataracts, but not pediatric glaucoma. So pediatric glaucomas, they themselves present late, or rather I would say that pediatric glaucoma, if you are late by a month, visual acuity will go away. So pediatric glaucoma, normally pediatricians do not miss because the complaints are severe, the eyeballs are very big, patient comes with tearing, ophthalmos. Normally it is not, it is very hard to miss. I mean,
Even congenital glaucoma?
Yes, sir. It is very hard to miss because pressures are huge. So the kid keeps on crying. There are descemet tears. There is photophobia. So immediately they are sent to ophthalmologist. But even when, I mean, we have operated kids as young as 3 days, 10 days, but the results are not very good. I don't say that we should not operate. The results are good. If we don't operate, they would be totally blind. So they have good ambulatory vision. That way, it is very rewarding that kid can do his own activity. The vision is almost 60 to 80%. So that is quite good in a condition where, you know, the kid may end up being blind.
So all questions in the chat box have been addressed in a rapid fire fashion. Thank you so much, Dr. Jethani. It was a really very informative talk, and you covered most of the areas of pediatric ophthalmology. Sometime later, we'll call you again for discussing certain specific issues, like people are interested in squint and more of refractory error. So we'll have some talk later on. So thank you so much for accepting our invitation.
No, sir. Thank you for calling me.
Yeah. And thank you all friends for joining the meeting, and we'll meet next Saturday again. And we have a very interesting topic to be discussed by Dr. Tushar Choksi, and that is metaverse in healthcare. So
yes,
again,
I'm going to speak.
Yes.
I'm going to speak on this topic. Yes.
So metaverse in healthcare. So I'm looking forward to that interesting talk next Saturday. Thank you, Dr. Tushar, for agreeing to be our guest speaker, although he's part of the Saturday Club. Thank you so much, Tushar, and thank you all. We end the meeting here. Thank you.
Thank you.